people are largely unaware of what happens with different kinds of cancers, and when they hear the C word, all they can think of is how much more time do I have left to live.
Right. Hello and welcome to Doctor Story, everyone. Breast cancer, a cancer that forms in the cells of the breast. According to World Health Organization, breast cancer is the most common cancer among women worldwide, claiming the lives of hundreds of thousands of women each year and affecting countries at all levels of modernization. Today we have invited Dr. Manjula Rao, M.B.B.S and M.S General Surgery, awarded 2 fellowships in breast oncology, one by the Hinduja Hospital and another by Tata Memorial Hospital, Mumbai. She has also been awarded gold medal in M.B.B.S and she has been invited as keynote speaker in many national and international meets. With close to a decade's experience in breast surgical oncology, she is currently practicing as breast specialist and oncoplastic surgeon at Apollo Proton Cancer Center in Chennai. Dr. Manjula, it's an absolute pleasure to have you here. A warm welcome to Dr. Story.
Thank you so much, Anjal. It's my pleasure to be on Dr. Story as well. So thank you for inviting me.
So, doctor, most women say their breasts feel lumpy or uneven. I'd like to ask you, what is a normal breast?
Everyone's normal is different. We say that, not just in terms of looks, but even otherwise, everyone's normal is different, right? So similarly, it's with breasts. They come in different shapes, different sizes. The nipples and the areola look different. Some of them, it may be very prominent. In some of them, they may come with retracted nipples since birth. That is where the nipples are inside. So everyone's normal is different, which is why knowing what one's normal is very important.
Absolutely. Coming to this breast cancer thing now, we understand that breast cancer occurs when, some breast cells begins to grow abnormally. But why does that happen? What are the causes of the same?
There is no one particular cause that can be attributed to breast cancer. So, yes, when the cells start growing uncontrollably, breast cancer occurs. Now, why does that happen? Obviously, there is a break in the normal process that happens. So, this could be genetic, but that occurs in only 10% of the patients, where they may be known to carry a known genetic mutation. But in the remaining 90% of the patients who develop breast cancer, the cause is said to be sporadic. Breast cancer is mostly attributed to an increased exposure to the hormone estrogen, which is a hormone that is normally occurring in every woman. So certain causes, such as women who get menarche, that is, they attain their menstrual cycle at a very early age, and then they attain menopause at a more advanced age, or say someone who gives birth after the age of 30, someone who doesn't give birth to children at all, does not get pregnant, someone who doesn't breastfeed. So all these are factors that increases a woman's exposure to the estrogen hormone, and that is said to add to the risk of a woman contracting the cancer. So in fact, the main risk factors to contract breast cancer is 1, being a woman, and 2, advancing age. So being a woman who's growing older every year itself is a major risk factor to contract breast cancer.
So as you mentioned about genetics, are women who have close blood relatives also with breast cancer more vulnerable or are at higher risk then?
Yes, there may be. Not just breast cancer, even women with family members, say, who are suffering from ovarian cancer or say prostate cancer, etc. All these adds to the risk, but exactly what is their risk of developing cancer this requires to be calculated. So for this, they can see a genetic counselor. There are online, there are these modules, risk assessment models that help to determine one's risk of contracting breast cancer. So women who are who have a 20% or more risk of getting breast cancer, that's when we would advise them to go see a breast surgeon or an oncologist, so that they put on personalized screening modules, so that every year we can keep an eye on them. And of course, all women are advised self-breast examination from the age of 25 onwards, or even earlier. Again, this is so that they know what their normal is.
Okay, what is this self-examination?
So self-breast examination, where a woman examines herself. So there are two steps to this. One is a woman must look at herself. She must know what her breasts look like normally. And the second is to know what it normally feels like. Okay, so when the first step is like inspection, and then you have palpation, right? So and it just takes 5 minutes of the woman's time. So what she needs to do is stand in front of the mirror and just look at her breasts. Look at what level they are at. Are they drooping? What we call ptosis. Look at what the appearance of the skin is like. Is it freckled? Are there any marks? Is there a dimpling? And she must look at her nipples and the areola. Is there any dryness? Is there any ulceration? Are the nipples pulled inside? What do they look like normally? So there are certain women who are born with nipples retracted inside. So so they need to be aware that this is their normal, because sometimes cancer can also appear with a retracted nipple, right? So that is inspection, where she looks at her breasts and sees what they normally look like, and she needs to do this every month. The other thing, the next step is palpation, right? So for palpation, she needs to feel her breasts. So very often what women do is they, examine their breasts like this, like they clutch at it, right? So what happens is, the breast is an organ that is, even otherwise, it's very, lumpy, and it's got bumps and nodules and everything. So when a woman starts clutching at her breast and examining it, everything's going to feel like a lump or a bump. So what she needs to do is use these three fingers, the index, the middle, and the ring finger, and use the pads, right? Use the pads of these three fingers to examine. So if this is the breast, she needs to examine herself like this, right? So you don't clutch at it, you just press against it, so that you're pressing the tissue against the chest wall to find out any abnormality. So in this case, if there is, say, a lump that is sitting beneath, or say a change in texture, when you do this, you're going to feel it, right? And how do you start? You can start examining yourself from the collarbone, right? So from below the collarbone all the way to the undersurface of the breast, where it joins the chest wall, right? Even that crease, the inframammary crease, should also be felt. And then from the center, the breastbone or the chest, the sternum, all the way up to the underarms, the woman must examine herself. The other way to examine herself is start from the center. So start from the nipple, feel what behind the nipple it looks like, the areola, and go in concentric circles all the way until you cover the whole breast up to below your collarbone, and also go into the underarm area. Okay, because very often than not, there may be a lymph node that is sitting there, something that is enlarged, which can sort of get camouflaged by the fat. Okay, so this is palpation. Now, it's important that the inspection and palpation is done in three positions. One is the woman just, stands in front of the mirror with her arms down. The second thing that she needs to do is raise her arms. So raise her arms up, and she needs to look at any changes. Is there any dimpling that occurs in the undersurface of the breast? And then, of course, she needs to keep her arms akimbo like this on her waist, on her waist, and then examine for any changes. Right. So I think it's important to do it in each of these three positions, and this can be done when she's either taking a bath or and I would actually recommend and when she's lying down, because different positions make different abnormalities more prominent. Say a lump which is not very prominent on standing suddenly becomes more noticeable when she's lying down. Do it so inspection and palpation, do it in the standing position and in the lying down position. So self breast examination is when a woman examines herself month on month. She does it by herself. She doesn't need to go to a clinic or to a professional. And by doing this month on month, she is aware of what her breasts normally look like and feel like. In the case of any abnormality or anything that happens, any change that occurs all of a sudden, she knows that she has to go and see a doctor.
Could you elaborate more on this change? What would be that change that one should go to, see a doctor about it?
It could be it could be anything that's a deviation from the normal. It could be a lump. The lump could be painful. It could be painless. It could be any change in the skin of the breast. There could be a discoloration. It could become red. The skin may be puckered or dimpled. It may be retracted inside. There could be a change in the nipple and the areola. It can start getting crusted. There could be nipple discharge, lumps or masses felt in the underarm area or the axilla, as we call it. So all these, any of these changes may point to maybe a developing abnormality in the breast. It need not necessarily be cancer. 90% of the lumps that women find, especially in their premenopausal age, in the younger ages between 20 to 40, they're mostly benign. However, a cancer cannot be ruled out, so it's very, very important that they need to go see an oncologist.
Does ill-fitted undergarments worse the case? And if yes, and how?
So there's a lot of myth that is associated with undergarments, be it their fit or their ill-fit in this case, or be it different colors, wearing say black colored undergarments or wearing bras at night while going to sleep. But like I said, they're all myths. There is no truth, or we haven't found any evidence that attributes an increased risk for breast cancer in such cases. So no, there's absolutely no truth to it. I think women, they're free to wear undergarments of their choice, their color. But yes, the fit is very, very important. More often than not, women are not aware of the exact breast size, and more so because different brands have different sizing guides. So it's very important that they go to a proper lingerie store and get themselves fitted. So in case of women with say much heavier breasts, it's important that they have they wear good supportive bras with broad shoulder straps such that it does not cut into the fat of their shoulders. They should have broader wings in the side, which sort of supports the breast at the side as well, so that it does not pour out from the sides of the bra. And another reason is during the premenopausal age group, a lot of women suffer from breast pain. So a well supporting undergarment aids that. It helps to reduce the breast pain because it supports the breast well. So the right fit is very, very important.
All right. Coming back to the cancer, how early is it possible to detect such cancers? What are the early symptoms attached to it?
The early symptom, of course, is for somebody who is examining herself regularly, she may find some change in the skin, be it a puckering, a dimpling. Someone may be able to find a lump that was not there before. But the earliest that a cancer, breast cancer, can be detected at is also at a non-palpable stage. That is, when it is not felt, the lump is not felt, or any changes in the breast is not felt in the fingers. And that happens when a woman starts screening herself. So when I say screening, I mean trying to find the disease before the symptoms manifest itself.
So, doctor, how can one actually do this screening? As you mentioned that it's the best one can early, detect such cancers.
In the West, they have nationalized screening programs, that is, screening programs that are run by the government for the people. So, wherein, depending on the country, every country follows different guidelines. So, depending on the country that they belong to, say in the US, they start screening from the age of 40 onwards once a year, where women are called for annual mammograms. In the UK, they usually say starting from the age of 45 to 50 onwards. In India, we follow Western guidelines, right? And because in India the cancers occur at a much younger age, women in their 40s are also vulnerable. We see a lot of women in the younger ages getting it. So we advise women to start screening themselves if possible at the age of 40. So maybe between the ages of 40 to 45, they can get mammograms once in 2 years, or even once a year is fine if they're able to do it. And starting from the ages of 45 onwards, once a year. So that would be an annual mammogram. In women who have very dense breasts, their oncologist or the breast surgeon may advise them supplementary investigations such as an MRI to visualize the breast better. We have discussed about the screening protocols for women that it starts from the age of 40 onwards. Now, a lot of people ask me, what about women less than 40? So we don't advocate routine screening in women less than 40. But yes, a certain section of the population who are high risk. By high risk, I mean who have more than 1 or 2 first-degree relatives with breast cancer, more than 2 second-degree relatives with, say, breast, ovarian, or other cancers. Somebody who's known to have a genetic mutation, like, say, Angelina Jolie, when she got herself tested and she was found to have the BRCA mutation. So these are some of the people who fall under the high-risk category. So in such women, it's important that they go see their oncologist or their doctor, meet a genetic counselor, so that we can calculate the amount of risk that is attributed to them. So anything more than 20%, we put them on a personalized screening protocol. So such women, we may ask them to get mammograms alternated with MRIs of the breast once in 6 months or so. But this requires a detailed discussion with the oncologist. Otherwise, routinely, women less than 40, what you all need to do is just do a monthly self-breast examination, and you can start your routine screening from the age of 40 onwards.
Is it common in men also, such type of cancers? If yes, how common is this scenario? Yeah.
Breast cancers can occur in men, not very common. Only 1% of the men may possibly get breast cancer. Yes, but it does occur in men.
Okay, and is the symptoms and everything, the treatment process, all remains the same with men also?
They're all mostly the same. The symptoms, all that is the same. In men, of course, the breast cancers, they reach an advanced stage more quickly, only because they have very less breast tissue. So in women, there's a lot more breast tissue, so it takes time for the lump to grow, to reach the skin, to reach the underlying muscle, to go to the neighboring nodes. But in men, there's hardly any breast tissue. So if anytime they feel a lump, it's better that they get themselves checked. But because the cancer is so rare in men, we don't have a screening protocol for them. We don't really have any protocol that we don't really have any guidelines that say that they should do a self-breast examination once a month or something like that. But being aware is always very important, as long as they're aware of the signs and symptoms of the breast cancer. And they should also be aware of their family history. So if they know that they have higher number of cancers in the family, they know that they have first degree relatives such as a mother or a sister who has had the disease at a younger age, then they need to be very careful, and they need to be aware and mindful of any changes that may occur.
Talking about diagnosis, how is it done medically? Like, once the patient or the woman comes to the hospital, to your clinic, what's the next step? If you could take us to the whole procedure and the journey of it.
Definitely. I think this is a very, very relevant question. People need to be aware of what goes into diagnosing, finding out what's wrong with them before we actually start with treatment. So the most important thing, the first thing that we would do is a detailed clinical examination in the clinic, where we look at we ask them their history, which includes the family history, surgical history, their comorbid conditions, and then we do the clinical examination to see whether the signs are correlating with their complaints. And then based on the clinical findings, we get a few tests done. More often than not, the first thing to do is breast imaging. So breast imaging will depend on the age of the woman. Somebody who's maybe 40 years and above, the first thing that I would do is get a mammogram done along with a digital, and we recommend a digital mammogram. So along with the mammogram, usually it is supplemented, it must be supplemented with an ultrasound of the breast, wherein the radiologist would correlate the findings of the mammogram with that of the ultrasound and then give us some information. So their report would include all that. And depending on the symptom that we're looking at, like say for example, if it's a lump, or say if it's a nipple discharge. So in the case of a lump, the radiologists often tell us the degree of suspicion attributed to it. So they would give us something called a BRCA grading, BRCA 1 to 5. So depending on the grade, we decide what needs to be done next. So typically any lesion which is a BRCA 4 or BRCA 5, we get the lump biopsy. Occasionally also lumps which are BRCA 3, but that depends on the clinical findings as well. Now women who are younger than the age of 40, it's not that we shouldn't get a mammogram done in them. Basically, younger women who are premenopausal, their breast density tends to be a little high. So there's not a lot of information that one can get by doing a mammogram. So in women less than the age of 40, we typically advise them an ultrasound of the breast, or in cases of higher suspicion, we get an MRI of the breast done. And if we definitely think that this could be a cancer, or say they've done a biopsy and we need some more information, then we ask for a mammogram. Because every radiological test that we have today, it has a certain sensitivity, it has a certain specificity. It gives us a certain amount of information. So we may need a combination of these modalities to come to not just the diagnosis, but also to formulate the treatment plan, and especially the surgical plan. Also, women over the age of 40, say they've gotten a mammogram done, they have gotten an ultrasound done, but from the mammogram, I find that the breast density is high, and there are there's additional information that I want. Then I may ask for an MRI as well. Okay. And also for certain complaints, like say a woman is complaining of a nipple discharge, then I would ask for an MRI so that I could get a detailed study of the ductal anatomy. Right? So that is breast imaging. Now once we have a breast imaging, so that is a picture. I get a visual of what the breast looks like, what is the abnormality, where it is, and why is the patient having certain symptoms. Based on the information that I get out of the imaging, I would ask for biopsy. So that is the next step. Say the most common complaint is a painless lump. Now we have the imaging. So the next thing that I need to do is I need to find out what it is, right? So clinically by examining the woman, based on the amount of experience and based on what it feels like, I would probably say that yes, this feels like a cancer. The imaging, the mammogram, the ultrasound would add to that evidence saying that yes, this is definitely looking like cancer, but only a biopsy wherein you're sampling the tissue involved, that is the gold standard for diagnosing cancer. So say somebody just comes with an ultrasound, that's not enough to start the patient on breast cancer treatment. You need a biopsy. So what kind of biopsy, you may ask? Typically, in any clinic, or if a general physician or a gynecologist or sometimes general surgeons, when they see patients, the most common investigation that is asked for is something called an FNAC, or a fine needle aspiration cytology. So what they do in that is they just put in a syringe, your regular syringes, they put that into the tumor and they take a sample. However, that is not adequate. So what we recommend, any breast lesion, any abnormality in the breast, we recommend a core needle biopsy. The difference between an FNAC and a core needle biopsy is simply the size of the needle. So a core needle is thicker. So a thicker needle means more amount of sample. So when you get more sample, there's a more accurate diagnosis and you get a lot more information about the kind of cancer there is, or other features such as is there lymphovascular invasion, etc., etc. These are just pathological terms that we're looking for. And typically, if we suspect a woman to have cancer, there are certain immunohistochemical markers that we ask for. And this is important for every patient to know that apart from the biopsy, from that material, we're looking for something called estrogen receptor, progesterone receptor, HER2 receptor. So these are certain hormonal receptors and proteins that are present in the breast, and we need to find out that expression in a patient with cancer, because that is going to guide our treatment. So how I often explain this to patients is, now doing a biopsy is trying to find out a person's name, right? Like I ask you your name, your Anchal. So doing the biopsy tells me your Anchal. But the ER/PR/HER2 gives me an insight into the character of the cancer. So that tells me what is the person's character so that I can behave accordingly. Similarly, I'm trying to find out what is the nature of the cancer so that we can address it specifically. Which is why I say that breast cancer treatment today is personalized. So not every patient with breast cancer receives the same kind of treatment. So now we start the imaging, we have a visual, we have done the biopsy, so we know that yes, this person has cancer. The next thing to do is to stage the disease. So how much has the cancer, where is the cancer, has it spread? So the way we do this is of course a combination of one clinical examination wherein I look for the patient, I look for whether there's any nodal involvement, whether it has spread to the lymph nodes. If it has it spread to the lymph nodes of the underarm? Has it gone to the neck? Right? So we look at that, and then we get a PET scan done. Right? So a PET scan is a test which gives us information about a visual of the whole body, and it gives us information as to where has the cancer spread. Right? Sometimes some doctors wouldn't ask for a PET scan. They would just, especially in those who cannot afford. So in institutes, bigger institutes, when we have patients who cannot afford, say, a CT scan or a PET scan, we get basic tests like an ultrasound of the abdomen and pelvis, a chest X-ray, and a bone scan. But these are three different tests, and sometimes, a chest X-ray may not be adequate. to find very, very small nodules, spread of the cancer to the lungs. So if possible, we would recommend, and also as per the NCCN guidelines, we would recommend a CT scan of the chest, abdomen and pelvis, and a bone scan. And if you don't want to do two tests, we routinely recommend a whole body PET scan. So that's just one test. It gives you information about the whole body at a glance. So these are the basic tests. Like every patient who's diagnosed with breast cancer needs to get these done: breast imaging, biopsy, and PET scan or some test for staging of the disease. And with this information, we have staged the disease, but sometimes, certain cases, we may need additional tests. For example, say a patient with stage 4 disease. A PET scan has revealed some nodule in the liver or something in the lung. Now, we don't know what it is. It could be cancer. It could be something else. It could be tuberculosis. In a country like India, that's very common. So in such cases, we may ask for additional tests, sometimes an MRI, definitely a biopsy to characterize that particular nodule. So yes, it varies from patient to patient. But these are the basic tests that we get done.
Well, you have actually elaborated the whole complicated process with such simpler terms. It's become really simple for all of us to understand. Coming to the treatments, what are the treatment options related to breast cancer?
Okay. So treatment options, you have 4 kinds. You have surgery, there is chemotherapy, there is radiation therapy, and there is something called hormonal therapy, right? It's a combination of plus or minus of either 1 or 2 of these treatments or all of these treatments that may be involved in treating the patient. It largely depends on the kind of cancer one has, the size, the extent, so that is the stage of the cancer, the age of the patient, and what surgical procedure has been done to treat them. Right? So breast cancer treatment today is a very, very personalized, has a very personalized approach. So if you have, say, 5 different women in the room diagnosed with breast cancer, each of those women may be receiving different kinds of treatments in different sequences. So it's not all going to be the same. And today we've also come a very long way from, say, 2 decades or 3 decades ago, when all of them would probably require removal of their breast. So today definitely things have changed. It's a very, very personalized approach.
When we talk about suffering, what is the intensity of the suffering? Is it painful or discomforting, these surgeries or the treatment options that you mentioned?
I would really hesitate to label these treatments or comment on the degree of suffering because it varies from person to person. I think a large extent of the suffering that one undergoes, or the emotional and the mental turbulence that one undergoes, is contributed largely by the fear factor that exists in society about cancer. So there is people are largely unaware of what happens with different kinds of cancers, and when they hear the C word, all they can think of is how much more time do I have left to live.
Right.
But the situation is not really that dire. There is a lot of hope, and today when it comes to breast cancer patients, we're talking about survival, we're talking about improving their life after breast cancer treatment. We have patients even in stage 4 who are doing well maybe 10 years after the diagnosis. So it really depends on what kind of cancer they have, and it depends a lot on their attitude. There might be a woman who's, say, undergoing chemotherapy and who's really struggling with every cycle, and she has a lot of side effects. There may be another woman who, for whom the treatment is a breeze. It's a lot like pregnancy, it varies from woman to woman, from person to person. For some, it may be a breeze. For some, the same treatment, like say, let's talk about chemotherapy, right? The same treatment can have different effects on different patients. And a lot of factors contribute to this, mainly the woman's emotional status, the emotional support, her mental health status, and the mental health support that she has. Also, financial capability. That really impacts what the woman goes through during treatment. It's very important to be financially secure. It's very important that people, take insurance policies to safeguard themselves, just in case, God forbid, but they suffer from cancer at some stage in life. So I think these are the factors that are very important. The kind of support they have, their attitude towards it, and also the financial support.
And when we talk about the advances, as you mentioned, in recent years, owing to the technological advances, is there any good news about breast cancer trends?
Lots. Like I said, breast cancer treatment today is very, very personalized. Say 20, 30 years ago, that was not the case. Every woman would probably receive chemotherapy. Every woman would, there would be radical treatments, radical surgeries done where the whole breast would be removed, the underlying muscle would be removed. They would come with, after breast cancer treatment, women would very often have developed swelling of their limbs, their upper arms, and we call them elephant limbs, similar to what someone with filariasis would develop. So that's called lymphedema. But all that has seen a change today. So today, when it comes to surgery, we're talking about not just conserving a woman's breast, but we're talking about even making it look similar to their opposite breast, and we're talking about cosmesis. So we're talking about making the operated breasts look good. So we utilize certain techniques called oncoplasty. We utilize plastic surgical techniques along with cancer surgery to help us achieve that. We are talking about, we're giving a lot more importance to a woman's emotional and mental health during treatment. So we're trying to, we talk about body image. So very often in my clinics, I ask the woman what she wants. So if somebody has to undergo a mastectomy or a removal of the breast, if she's not very comfortable, we offer her options of reconstruction of the breast, which I think talks about a vast shift in the thought process and also advances in medical treatment. Absolutely. The other thing is chemotherapy. Chemotherapy earlier, it used to be compulsory, but today it depends on the kind of cancer that she has. Certain kinds of breast cancer may not require chemotherapy, so we just treat them with surgery, radiation, and maybe some tablets like hormonal therapy to help them. And then, of course, even the radiation techniques have changed majorly over the last few decades. So at once upon a time, the whole area would, the area that was radiated in the woman, it would look like completely burnt and dark. But today that's not the case, even in a woman with an intact breast, when we radiate, we are able to achieve very, very good outcomes. So a lot of change has been happening in the field of breast cancer almost on a regular daily basis.
Wow. Okay, finally, what can one do to reduce this risk? What would be your top suggestions for all the young women and, reaching their mid-age, watching you, the best suggestions that you can give to them?
So, my top suggestions would be: one, adopt a healthier lifestyle. One of the things that I did not mention when we spoke about increased risk at the beginning of the talk was, the lifestyle, the modifiable risk factors. So, we eat outside very often. We eat a lot of processed food, high salted foods, barbecued foods, a lot of red meat. So if you can reduce all that, reduce the amount of alcohol intake, stop smoking. All that reduces one's risk of contracting not just breast cancer, but other cancers as well. So obesity, we it's very very important to stay fit and to adopt an active lifestyle. Obesity causes almost 15 different types of cancers. Smoking causes so many different kinds of cancers apart from just breast cancer. So my top suggestion would be adopt a healthier lifestyle. That will definitely help you to reduce your risk. Stop smoking, fit lifestyle, reduce obesity, focus on what you're putting inside your body, be more active. And then, of course, fourthly, which I think is very, very important, is monthly self-breast examination, irrespective of your age. Know what your normal is and be aware of what's happening within your body. Be mindful of the changes that you may be undergoing. And finally, the fifth, I think, is the most important, is be aware and spread this awareness. So, educate your family members, your relatives, your colleagues on whatever you've learned today. Say you've learned a symptom of breast cancer, talk to them about it. So don't shy away from discussing these issues, because the breast is also another part of your body. Everybody has it. So I don't think one should shy away from these issues. And just like somebody would suffer from, say, a stomach upset or, say, a pain in their leg, similarly, there can be issues with the breast as well. So don't shy away from getting yourself shown or talking about it, or speak up.
Well, indeed, it's been such an insightful discussion addressing breast cancer with you today. Well, I couldn't thank you enough for the time you have taken off. Truly appreciate the efforts you have been doing in this field. Thank you so much.
Thank you so much, Anchal, and thank you for having me on Dr. Story. Such a pleasure.